Hi, Mrs. Garcia.
Hi,
I'm
Dr.
Hyung
Kim.
Kim. Nice to meet you. While waiting for you, I had a chance to look over your medical records. I have your pathology report and the x-rays. I'd like to ask you a few questions to fill in some of the blanks we have. What was the symptom that led to the workup that led to the diagnosis?
Well, it was just I had blood in my urine. My urine was different
Any
color.
other symptoms associated with the bleeding? Pain anywhere, burning with urination, fevers, chills, nausea, vomiting?
No, that was it.
And are you still having the bleeding?
Not anymore.
Okay. The pathology report I have shows that you have a bladder cancer and that the cancer is high grade, meaning it looks aggressive under a microscope, and that the tumor appears to be growing into the muscle of the bladder. Is that your understanding as well?
Oh my gosh. Well,
Yeah.
now it is.
Okay. Well, let me draw you a little picture that illustrates what it is that we're dealing with. So the bladder has several layers. So I'm going to draw a couple layers here. And this is the inside of the bladder. Okay. And bladder cancers can be invading the bladder to different depths. And so if the bladder cancer is going into just the top layer, this is something we label as TA, then it's T1, T2, and T3. And this layer is the key layer. It's the muscle layer. And once the bladder is in at least a muscle, we label this as a deep tumor. And the significance of a deep tumor is that in order for us to try to remove it completely through an endoscope, by going from the inside and scooping it out, we risk perforating the entire bladder and punching a hole in it. So what we really have to do is remove the entire bladder. We can't differentiate a T2 from a T3 based on a biopsy. So we know you have at least a T2 because the biopsy showed muscle with tumor in it. The other reason why a deep tumor requires complete bladder removal is that the vessels, blood vessels and lymphatic vessels that can potentially carry these tumors throughout your body and cause them to spread are in the muscle. So a muscle-invasive bladder cancer has the potential to spread and become incurable. Right now, based on your x-rays that we have, your CAT scan of your abdomen and chest, we see no signs of spread. So although we're looking at a big operation, it certainly appears that this is a cancer that's treatable and hopefully curable. Okay? But let me tell you a little bit about the operation we're going to need to do. So in order to take the entire bladder out, we would do an operation that would involve an incision on your abdomen. So historically, we used to make an incision below your belly button in the middle. And this used to be the open approach. Now many doctors will perform the same operation robotically. So instead of making one big incision, we make a couple keyhole-sized openings, and we put a camera inside. We use long instruments with little graspers at the end, and then this is robotic surgery. Now I will tell you that whether you do it open or robotic, the outcome's about the same. Recovery is about the same. So you should just have the operation using the approach that your surgeon prefers and is most comfortable with. In my case, I like to do these operations robotically simply because I can see better and it's more comfortable for me and the surgical team. Now what is important is the reconstruction that's done after the operation. So once the bladder has been removed, the urine has to go somewhere, right? So we can do one of three different types of reconstructions. So if your kidneys are here, we can take the intestine and create a new bladder. This is called a neobladder. We can also take the kidneys and connect it to a small segment of intestine and bring the other end to the skin, and then you would wear a bag on the outside, and that's called an ileoconduit. And then the third option involves taking your kidneys and creating a new pouch that looks a little bit like the neobladder, but instead of connecting it to the urethra so the urine comes out the opening that you currently urinate through, we create a little channel and then bring that channel out to the skin. And so when the urine, which gets stored in this new pouch, needs to be emptied, you put a catheter into this little stoma. And sometimes that stoma is right where your belly button is, and you can empty it that way. This is called an Indiana pouch. Now, when we do the operation, we would take out your bladder, we would take out your uterus, we would take out your ovaries as well. So those are all structures that we typically remove in women who are not of childbearing age because it helps ensure that all of the cancer gets removed. We would also be sampling the lymph nodes in your pelvis. These are small structures at the edge of your pelvis that we would sample and remove because the cancer often spreads there, and we would like to know if there are cancer in those nodes. Okay. So when you think about the 3 reconstructions, you might think that the neobladder is the most natural looking reconstruction, and that's true. It is most similar to your current bladder. However, it's also the most complicated procedure to perform, and as a result, the side effects and risks are higher. The ileoconduit is actually the simplest of the reconstructions and has the lowest complication rate. If you consider hospitalizations that might occur after the surgery as a result of a complication within the first year following the surgery, after a neobladder, the risk of hospitalization is about 50%. Whereas with the ileoconduit, that's 25%. And then with the Indiana pouch, it's similar to the neobladder. Now we might do an Indiana pouch rather than a neobladder if the urethra, which is this structure here, is also diseased and needs to be removed, in which case the neobladder is not an option. It would really have to be an Indiana pouch if you want to avoid having a bag that you wear on your skin. Also, you can have a complication that requires more surgery. So I'm going to write here more surgery. And the risk of needing another operation after the cystectomy or bladder removal, if you have a neobladder, is about 40%.
Oh, that's not good.
Yeah, so in younger patients, if you have a major operation and for some reason you need to have a second operation, they can usually tolerate that. But for older patients, if you're having to have another operation after you're still trying to recover from the first, the second operation can be a big deal. So generally speaking, for patients over the age of 70, for example, I almost always recommend an ileoconduit for that reason. Now you have 70-year-olds who are healthy and functioning at the level of a 60-year-old. In that case, the physiologic age is more important than the actual chronologic age. But for the typical American who's of average health, 70 is sort of a cutoff where I think the ileoconduit makes sense. If you're younger, certainly below the age of 60, I think a neobladder makes a lot of sense. And you're strong enough and young enough and healthy enough that you can have one or even two operations if there's some reason to require a second operation. So the risk of needing more surgery after an ileoconduit drops to about 20%, and then with an Indiana pouch, it's closer to 40%. The complications after any of these diversions or reconstructions include a urinary infection. You can get a urine leak. You can get scar tissue and strictures where the ureter and the neobladder connect, these points. Any of these complications might require more surgery. You can also get a bowel obstruction because these new bladders are created using intestine. Now with the neobladder, an additional complication that you have to be aware of is incontinence, meaning you're leaking urine and having to wear a diaper. Most patients have some degree of incontinence after the procedure, and over the next couple of months, the incontinence improves. But the first thing that'll happen is that your incontinence at night will get better, and then the incontinence during the day will get better. But in about 20% of women, the incontinence at night never goes away. And in about 30%, the incontinence during the day never goes away. So that's leakage that you would have to wear a pad or a continence pad for the rest of your life. In about 10% of patients, the bladder doesn't empty properly. So your natural bladder squeezes when it's trying to empty. The neobladder is made of intestines, so it can't squeeze the same way your native bladder can. So the way you empty it is that when you have to urinate, you squeeze your abdominal muscle. But depending on where the bladder sits and depending on how the position the bladder is in, you may not be able to completely empty it just using your abdominal muscles. And so there are about 10% of patients that require a catheter, meaning you have to put a tube into the opening in the vagina to get the urine out and to empty it completely. So they need a catheter every 4 or 5 hours when their bladder is full to empty it. So as you can see, these are complications that are unique to the neobladder because you're urinating the normal way, through the normal channel, that is. The ileoconduit and the Indiana pouch do not have these complications relating to the incontinence or the hypercontinence where you need a catheter. Okay, so I'm going to give you these. I know this is a lot of information, but you'll have to think about your options. You'll have to discuss them with your family and then let me know what type of reconstruction you want. And keep in mind that the more complicated the reconstruction, the higher the risk. So couple of other things that I do want to make sure you understand. The surgery is the primary treatment. It's the most important treatment that you're going to need at this point. But you can optimize the outcomes from surgery by giving chemotherapy before the operation. So it's usually given over a month and a half or 3 months, depending on the type of regimen you pick. And I would have you see a medical oncologist to talk to you more about this. But what chemotherapy will do for us is it'll improve our chances of cure by about 15%. So I want you to meet with a medical oncologist to talk about chemotherapy. And then we would schedule the surgery after the chemotherapy has ended. And finally, I would also like you to meet with our radiation oncologist. So although in this country, most patients with bladder cancer, like the one you have, will undergo surgery and often with chemotherapy, another treatment option involves a combination of chemotherapy plus radiation. And this may allow you to keep your bladder and not have to remove it. Now, keep in mind that the combination of chemotherapy and radiation doesn't always completely treat the cancer. And if there is cancer left over, you would still need to have your bladder removed. And so the downside is you're going to have a full treatment using chemotherapy and radiation and then need surgery even after all that. And that happens roughly in about 50% of patients. So you could argue that this would be this is a good treatment approach because you're avoiding surgery in many cases, but you can also argue that this is sort of a bad approach because you're adding another treatment to a course that's already long and complicated. Okay, so I know this is a lot of information, but I think the best way to think about all this is, first of all, make sure that surgery makes sense. I would also consider the radiation option, and you should meet with the radiation oncologist. And then if you pick surgery as the treatment you want to go with, then you need to think about the urinary diversions and see how you want to proceed there. And what I like to do is I want to give you my email address and phone number so that as you have more questions, you can call me. I know these are very big decisions that you're going to need to make. And so I want to make sure you sleep on it, think about it, and make a decision that feels right for you. And we can plan, if you'd like, to meet again in about 2 or 3 weeks to answer more questions you might have. If you're comfortable thinking about this and making a decision based on what we talked about today, you can let me know, and we can help schedule things accordingly.
Oh,
Okay.
I want to live. So, so I really think we need to do it in steps. We need to do the chemotherapy and radiation first. Let's see how that goes.
Sure.
Let's see. And if it doesn't go, then you know what? They make all kinds of clothes that can hide this bag. And this seems to be the best option to me.
Sure.
Yeah, I mean, I'm an alpha female, and let's go. Let's get me in. Let's.
Okay. I like your fighting attitude. You're going to need all the optimism that you have, and I think we have good reason for optimism, but it is a long course, and there will be lots of bumps along the way, so I want you to maintain that fighting spirit. I'm going to talk to our radiation oncologist, make sure they can get you right in. I think you're making good choices here, and let's try the chemotherapy and radiation first, and maybe we can save your bladder. If not, we're always ready to do your surgery for you. And I know the bag with the ileal conduit might sound a little strange at first, but if you actually talk to people who are using who have the bag a year out from surgery, they report a high quality of life. And once they get used to having the bag and get used to dealing with it, it's like putting on shoes in the morning. It becomes really second nature.
Right.
Okay. Well, let's stay in touch, and let's see if we can get you through all this, okay?
Okay, thank you
All
so
right.
much, Doctor.